In anticoagulation therapy management, was the lead pharmacist for our anticoagulation services, and then in 2009 she became the clinical coordinator for the inpatient pharmacy. In 2014 she became director of pharmacy services at Ignatian. She's board certified as a pharmacotherapy specialist and serves on numerous committees.
Great, thank you. Can everyone hear me okay? All right, well, welcome to Pharmacy Potpourri. That's kind of what I'm labeling this talk. Of course, I have to start off by saying I have no disclosures. I'm still waiting patiently to be able to disclose something, that I've made some huge amount of money on some proprietary medication, but that just hasn't happened yet. So the objectives for my talk today are really a pharmacy emotional roller coaster. That's like kind of what I'm going to sell it to you as. I want to start out with some exciting information. What are some new drugs coming down the pipeline? What are we seeing out in the literature? Then I want to maybe scare you a little bit, or maybe relieve you a little bit, talking about medication safety issues. I want to bore you a little bit then by talking about pharmacoeconomics and pharmacy and medication expenditures, and finally maybe fire you up a little at the end to talk about medication shortages. So let's start off with the fun stuff. So the medication drug pipeline, in my opinion, has slowed up a little bit. We're not seeing kind of the advent of new primary medication therapies that we were seeing in the 90s and early 2000s. However, I'd like to highlight a few of the things that have come out recently. The first one I want to talk to you about is Giapreza, which is a synthetic human angiotensin II peptide hormone. Well, what it does is it really stimulates the RAS system and causes vasoconstriction and increased aldosterone release. And why are we using this then? Well, it was FDA approved in December of 2017 to be used for hypotension from sepsis or other distributive shock. We reviewed it at Therapeutics, and we have not decided to add it at this time. Why? So let me tell you kind of some of the whys behind it. With using this medication, it increases VTE risk. That was the biggest side effect from this medication. When you're looking at the cost, remember I said I was going to bore you a little bit by talking about how much drugs cost. When you're looking at the cost to treat an 80-kilo patient for 72 hours on this particular medication, vasopressor, which would be an adjunct of vasoconstrictor therapy that you could use, is about $1,200 cost. You're looking at phenylephrine, which would be another adjunctive therapy that you could add on to norepinephrine. You're looking at about $450 for that 72 hours. When you're looking at adding on Giapreza, you're looking at $9,000 for that additional treatment. So that in mind, and then we reviewed the data from the ATHOS trial. So the ATHOS 3 trial was really the only trial that looked at the utilization of this medication in a clinical setting. And it was a trial, a random assignment of patients. There are 344 patients in the trial. The primary endpoint for this trial was to have an increase in MAP of a certain percentage or up to 75. And you had to have that increase without touching any of your other vasopressors. So just strictly working with the Giapreza. The primary endpoint for this study found that it was effective. So for 69.9% of the patients versus 23.4% of the patients, there was an increase in the mean arterial pressure. Great, right? What does that tell us about survival when you have a patient with sepsis or septic shock? And that wasn't really a focus of the study. And when you looked at mortality, 28-day mortality for patients who did receive the medication versus placebo, death rate was 46% for Giapreza versus 54% for placebo. So obviously not a significant p-value. And so what this study and what we discussed was really lacking was the outcome of the medication. So you increase the blood pressure. So what did that have to do with patient outcome and mortality from sepsis? The other thing that was a little bit of a concern is when you looked at the study, it looked at the patients who were in the study had to have high output shock. Okay, so how many of those patients do we really have that would have a high output shock? And so in patients who don't have the high output shock, is it really a less safe medication? I mean, are we putting our patients at risk? And in fact, some of the arguments for adding this medication, or not adding this medication to formulary, is that having angiotensin II around can actually increase mortality from sepsis in certain patient subsets. Next medications I want to talk to you about that are new in the pipeline are biosimilars. How many people are familiar with biosimilars? Okay, good. Not a lot of hands, so I'm really excited to talk about biosimilars. Biosimilars are basically generic drugs. They're generic drugs for large protein-based molecular drugs. You can't really make a generic for those. So because it is a protein-based structure, it's just a structure with a twist, maybe an anisomer here or a turn there. But basically, it is a similar product to the original product that it was approved for. So with biosimilars, we have 10 of them on the market now. We're really starting to see a boom in the last year and a half of biosimilars that are introduced. And so what biosimilars have to do is basically go to the FDA and say, hey, I want to go after this indication that the primary product has, and I'm going to prove that I'm efficacious, and then you're going to give me okay for all the rest of the medications all the rest of the indications for that particular medication. Great. They've been using biosimilars for quite a long time in Europe with appropriate results. When you look at medical society information, they say, yeah, go ahead, let's use biosimilars. They are a perfectly acceptable alternative. Why am I pro-biosimilar? Because remember that boring part that I talked about money that's coming up? Yeah, that's why I'm pro-biosimilar. Biosimilars can be far less expensive than the primary product. So for example, we carry right now biosimilars on our formulary. They're biosimilars for Remicade. We carry Inflectra and Renflexis. When I look at Remicade is about $1,100 for a 100 milligram vial. Most doses are, 5, 6, 7, 8, 900 milligrams. And when you're looking at the cost of a vial or 100 milligrams of Inflectra or Renflexis, you're looking at about $600. So it's almost half the price with the same clinical efficacy and outcomes. So right now the FDA is still kind of figuring out how are we going to regulate these products. There's a little bit of uncertainty. And so the FDA released a statement that said, and Wisconsin state law even amended the laws to say, hey, you know what, if a biosimilar is listed as interchangeable with the primary product, you can go ahead and interchange it without talking to the provider first. Yeah, the FDA hasn't done that yet. So we in pharmacy, I can't substitute a biosimilar without receiving okay from the provider. So, when you order Zocor, like nobody really orders Zocor, but when you do, we give you generics instead because that's what we do. But I can't just substitute a biosimilar for these products because of state and federal regulations. And again, the FDA at this time has not said, yeah, they're totally interchangeable products. So until that time comes, we're really kind of pushing at the point of ordering to say, hey, please consider this biosimilar to the product. Oops, sorry. Next medication I want to talk to you about is a new medication. It was just approved by the FDA in May of 2018. It's the next step. And it's a recombinant factor 10A. And what it really does is it binds to the 10A inhibitors, epsixaban and rivaroxaban, so the DOACs, and only 2 of the DOACs. There's really 5 DOACs out there now. This only binds to 2 of the DOACs. And it is scheduled to be for early release. In fact, I've been contacted about, are we going to have this at early release from the drug company? They're only releasing it to 230 sites in the United States. And what you have to do to qualify for this medication is either be a level 1 or level 2 trauma center, or you need to be a primary stroke center, and you need to see 1 to 2 anti-10A bleeds a month. I'm like, that's how we qualify for that. That being said, I envision that at some point we will have this medication on formulary, at least have access to this medication. Anyone want to venture a guess at how much the dose would be? $50,000. $50,000 for 1 dose of this medication. And so I have heartburn, obviously, about having it here on staff, or here in formulary, when we don't necessarily see 1 to 2 bleeds of the anti-10As. And we still have some appropriate treatment options with 4-factor PCC that we have here, and even factor 7. So there's really only one study that looked at the utilization of this. And it was a prospective open label single group study with 67 patients. And they measured anti-10A activity in a 12-hour period and a 30-day follow-up. And what they saw between rivaroxaban and epsixaban, there was an 89 and 93% reduction in drug level after 2 hours, and then at baseline there was a 39 and 30% reduction as well. And at 12 hours, they found that hemostasis was good or excellent in 37 of the 47 patients, so 79%. And patients, there was a thrombosis risk happened in 12 of the 67 patients. So have we had an ask to have this on formulary yet? No. I'm sure it's coming, and I will have a little bit of heartburn just looking at the price tag of this particular medication when we do consider it through formulary addition. All right, so we're going to switch gears now and talk a little bit about drug safety. And so my favorite organization, and I often said if I was going to get a tattoo, which I don't have, but if I was, it would be ISMP, which stands for Institute for Safe Medication Practices. I am a huge fan of this organization. They basically say, they give you like a book and they say, hey, don't do this stuff. We're going to help you not to do this stuff. And so that's fantastic. And every year or two, they put out recommendations. And this last year, they put out 14 best practice recommendations. And I just want to hit some of the highlights for you. I do take these 14 best practice recommendations to discuss at therapeutics to make sure that we, from a medication management point of view, are following these best practice recommendations. So best practice number 3 is to weigh patients as early as possible on admission and during appropriate outpatient emergency department encounters, and avoid the use of stated, estimated, or historical weight. And this is something that we run into with issues here. I was staffing a few weeks ago, which is like never heard of anymore. Like I hardly ever staff. Everyone in my staff gets really nervous when they see me staffing. I'm like, I still can do it. I promise I can still do this. I know how to do this. But I got an order for vancomycin for a patient. The patient was in the ED, and so there was no weight in the computer, and I called up to the nurse and like, hey, can I get a weight on this patient? Just kind of want to see where they're at. And you know, a couple minutes went by, I'm like, you know, hey, I could really want to give this patient their Vanco. I kind of need a weight. And she's like, well, there's a weight in there from February for this patient. I said, yeah, there was a weight in there, but the patient had a bilateral lower extremity removal. And I'm going, I think their weight may have changed. And so I need a more current weight, not a guesstimate, to dose this patient's vancomycin. The second part of this is to weigh and document patients only in metric units. Now this is something that I have been asking for and toting for years, and this is probably one of the greatest things about Canada is they do this. I'm really hoping we can do it here. But this is still an area of concern for us, and I am just putting this plug out here to continue to be a champion for speaking in metrics, weighing in metrics, as we look at medication dosing. Best practice number 8 is looking at using IV infusion pumps or smart pumps. So we have had Alaris pumps here, which are our smart pumps, since 2007. And we use those pumps in inpatient and outpatient settings. And the best practice is, you know, you really need to use these pumps. But you gotta make sure that you're using the error reduction software that's on those pumps. And you need to make sure you're keeping up with that data and looking at that data and making changes to the Alaris pumps. So when we put them in 2007, it was great. We put them in, we made this library, and we're all like, oh my gosh, thank God this project is done. Because it was a rather large project. You needed to have standard concentrations, you needed to build libraries, you had to put in guardrails, and it was fantastic. And we were kind of happy when it's done. But what we did, kind of through ISMP's prompting, is saying, you know, are we going back and looking at our smart pumps? Are we making sure that the alerts that are firing and the library that's in there is appropriate for bedside nursing to make sure that they're giving these potentially high alert medications within the guardrails and using them safe and appropriately? So first thing we looked at was the alerts. All of you love alerts, right? Alert fatigues, pop-ups, because they really make your job meaningful, and they don't, you know, they don't like dampen the worrisome from all the alerts. So we looked at the Alaris pumps, and what we found is that we have an opportunity for improvement. What we were noticing is we had an awful high amount of alerts, and alerts that were being overridden by bedside nursing. And so then it just becomes noise. And we looked and partnered with nursing and said, hey, what are you overriding and why are you overriding this? Is there something wrong with our library? Is there something we need to tweak or adjust? Is something not right? And so pharmacy worked hand in hand with nursing and brought in provider representation when we looked at the alerts and tried to really get rid of some of the guardrails in the alerts that were not appropriate for patient care, that people were routinely overriding. And so we made the adjustment to the pumps, and you can see we had a significant reduction in the alerts, which really allows them for bedside nursing to only be alerted when there is truly a problem when we're looking at the guardrails. So speaking of guardrails, so we build these IV pumps and we put in guardrails, which is our IV smart pump library. And it's really designed to allow for safe medication administration. Like, you can't give an insulin bolus of 100 units over 1 minute or something to that effect. But what we were finding is we had an issue with adherence to the Alaris library and the guardrails. We're like, what? We built it. Why didn't you come? We built it. Let's use this. And so what we did is we dove into our data. We said, what are our problem areas? And so if you look, the number one area that had the lowest adherence to the guardrails or the library was with our chemotherapy medications. Our chemotherapy are our highest risk medications. And so what was happening is the drugs weren't in the library, and nursing was bypassing that and giving it just as a basic infusion. So they were just looking at the bag and typing in the rate. Well, that doesn't really allow for the safety that we plan for these pumps. And so what can we do to make this better? If you look at the next group that had the lowest adherence to the guardrails, and it was in the neonatal library. Okay, those are, again, our high-risk patients, and we really need to make sure that we are using the guardrails and the safety features in that Alaris pump, because otherwise we're basically just using them as dumb pumps. We're not using that library and the safety software that was built in. For a few years now, we have been part of the IPI, which is the Infusion Pump Informatics. I mean, it's a real cool group. They do a lot of real fun stuff. But it's basically just data analytics, and it's run out of Purdue University. And what you can do is you can upload your your database and your alerts, and then you can compare yourself to your peers. And so we did that. And we were a little worried about where we stood with our peers. You can see Ignition Healthcare was 77% of our guardrail compliance, which means that we were using them essentially as dumb pumps. My favorite hospital, and I think if they ever call and ask me to come, I'll definitely go and work there, but UC Davis had a guardrails compliance of 99+%. So of course I'm competitive, and I'm like, whoa, we got to get our numbers up a little bit. So what we did is we worked with nursing, and we revamped some of the education. We also took a look at our pumps. So we had these smart pumps that we had in the system, and you know how we had to update the library? We had to take every single pump and plug it into the wall. And we have over 250 brains for the pumps. So we had to track them down and pump them and hook them up to the wall. And I'm like, well, don't we have wireless internet here? Can't we just like push a button? And the pumps didn't have that capability. So we did is we worked with supply chain and our biomed group and had appropriate SD cards installed in the pump. So now that we can just send it out and update with the push of a button. So it allows for much faster updating of our Alaris pumps. And you can see that our compliance to the Alaris pump library was at about 76%. And after we got done with our study and our intervention, we were well above 90%. This still holds true today. Over a year later, we are well into our 90%. In fact, oncology is well above 95% of adherence to the Alaris pump library. So kudos to them for making that change. Next best practice is best practice number 11, and what it talks about is IV room safety. I think if you have ever heard me talk about the IV room and how medications are prepared outside of pharmacy, and I'm talking injectable medications, I get really freaked out because we have to be very, very secure and very careful of how we compound medications in the pharmacy. However, ISMP is recognizing that we need to make the next step. And so one of the methods that we utilize, because did you know that pharmacists, we don't compound drugs? Like, I can't tell you the last time that I went into the IV room and started putting together medication. We have technicians who do that. But the pharmacist is really the verifier of the person who is compounding those medications. And so there are several different methods to do that. However, for me to go into our IV room, I have to glove and gown and put on a hairnet and a face mask and booties. I have to wash my hands 2 times. I have to put on gloves, and then I have to alcohol those gloves off. So can you imagine having a pharmacist go in every single time an IV is made, because we make an awful lot of IV medications. So you have to come up with other methods of how can we make sure that the right medication is in there. And so one of those methods is using what they call the syringe pullback method, where they mark on a syringe what they injected into the bag. Well, that's okay, but we can do it better. And so one of the things that we have implemented and are in the process of implementing here is installing gravimetric IV workflow software. And so what this gravimetric IV workflow software does is it says, okay, technician who is making the medication, here's the recipe for making the medication. Now you must barcode the drug that you're going to use. You must barcode the IV bag that you are going to use. And before you add that medication into that IV bag, you need to weigh it, because we're looking at the specific gravity of the medication and also with the syringe before we add it. Each step, it stops and asks for verification. It also takes a picture of everything that's been compounded. So we are using this for our high-risk chemotherapy medications, and we are moving this to expand to all of the IV injectable medications that are drawn up or prepared by pharmacy would go through this system. And again, it allows for safety and verification through the gravimetric software. It has barcode medication administration, or barcode verification. The state of Wisconsin said in the law update earlier this spring, you need to be able to track to the lot number of the medication the patient had. Okay, no computer system does that yet, but with this software that we put in, we are at least able to start that with the hiring process. Best practice number 14 from ISMP said, you know what, you need to see what your neighbor is doing. You need to hear what's going wrong in other hospitals, and we definitely do this. We look to organizations like the FDA or ISMP to provide us with guidance on how to prevent medication errors in our organization. And as you're aware, we have the Verge medication occurrence reporting system. We really believe in full transparency of those medication occurrences. And we do have a non-punitive culture. Last year, we had almost 1,000 medication occurrences reported through the system. Pharmacy reviews each and every one of those and looks for trends and starts process improvement projects based on that. But what's really is encouraging is to make it a non-punitive culture. We don't want to hide medication errors or any of the occurrences. We want to learn from those. So, once a month in the pharmacy department, I bring a summary of all the medication occurrences that happened in the system over the last 30 days. And I can tell you it is one of the most highly attended optional meetings that I have, and the pharmacists just sit there and they look and, you know, we don't want it to happen to us, but we also want to learn from what has happened, and can we make process improvements from these medication occurrences. Last medication safety topic I want to talk to you about is USP 800. Has anyone heard of USP 800? Does anyone know what USP stands for? I'll take you out for dinner if you do. I swear everyone was going to know. Okay, USP stands for United States Pharmacopoeia, and this is kind of like our organization that tells us how we have to compound medications. And they have lots of different standards that we have to follow. And the newest one is USP 800. Now, you may have heard, probably not, people talk about USP 797, and that's really guides how we prepare injectable medications in the pharmacy. And we're really trying to prevent adverse events from happening to our patients by ensuring appropriate compounding procedures are taking place. USP 800 is the flip side of that. Each year, more than 8 million people in healthcare are exposed to hazardous meds. And when I say hazardous meds, people think chemo. No, that's not hazardous. Oh my God, it is a hazardous med, but the list is far longer than just chemotherapy. And since the 70s, we've really started to take in account that, oh yeah, we have some hazardous drugs. Joint Commission has only requested that you have a list of hazardous drugs. And so until USP 800 came out, it didn't dictate what you did with that list. Well, now USP 800 says you're going to have to be very careful with those high hazardous medications. For example, facility design. I have to redesign 4 of our pharmacies because I have to have different engineering controls, different air exchanges, different humidities, different pressures, things I never thought I would have to talk about when I went into pharmacy school. But USP 800 is dictating that. So there is construction going on in all the pharmacies to make sure that we can adhere to those facility designs. Environmental controls. So in areas that administer or dispense hazardous medications, we will have to do wipe tests. So in urology, where they're utilizing BCG, we will have to do wipe tests on the counter once a month to see what level of BCG that we have there to decrease hazardous exposure to the people who are working in that environment. Significantly changes the amount of PPE people will have to use when they administer or handle hazardous medications. We label hazardous medications right now for bedside nursing who are giving medications, but this will change the amount of PPE that they have to have. And we're talking gloves, gowning, face shields in some cases. Medical surveillance. Right now we do medical surveillance for patients who routinely, or for people who routinely compound or handle chemotherapy medications. This will be expanded now. Yeah.
What's PPE?
Personal protective equipment. So like your gloves, your gowns, the whole shebang. No, that's all right. So for medical surveillance, we will be doing a lot more testing. And right now we only test people who compound oncology, but now we are going to be testing more and more associates. In fact, when we hire associates, we're going to need to disclose you may come in contact with hazardous medications and do some education around that. Lastly, they're requesting or mandating that we have to use closed system transfer devices. So closed system transfer devices are things we put on syringes and vials to make sure that we aren't releasing any chemotherapy particles into the air. So you can see in the upper example, there is a vial with some awful looking red drug in it, and a cute little satellite-looking dish thing, and a syringe. And everything that is, all the pressure in the air that you have to put in to draw up medication, any of the mist that would come off from that drug, from the vial, fills up into that cute little looking satellite dish, so it is all contained. On the bottom of the screen, you will see kind of some of the other adaptations that we have to use for syringes and IVs. And so this not only increases safety, which is a wonderful thing, but it significantly increases cost that we have to use to procure these products. They are very, very expensive. Now, USP 800 was supposed to be mandated July 1, 2018. Yeah, we're not even done with our construction. We're not even close to doing that yet, and nobody else in the country is. Nobody was really ready for the amount of regulation that we had to put in for this. And so they extended it to December 1st, 2019. That being said, we have a long ways to go. We're working in a multidisciplinary committee, and I wanted you guys to be aware of it because it is going to affect you and the people that you work closely with in dealing with hazardous medications. One other thing I want to highlight about the closed system transfer devices, we have used these here at Ignition for probably more than 5 years now. We had an oncology pharmacist who was really ahead of the game and brought these into our organization. So we have used these well before they were mandated. One of the nice things about using these closed system transfer devices is we are able to increase medication savings by allowing for extended expiration dating. So that's a good thing. All right, so now we're going to transition to maybe the little bit more of the boring part of the talk because it's going to be about money, not one of my favorite topics. But as you know, this is a prominent topic in the healthcare arena right now, especially having to balance patient care with the cost of medication therapies. So I'm going to present two different sections of information. I'm going to focus on the retail side, and then I'm going to talk a little bit about what we're seeing on the inpatient side. And so this information is from the Kaiser Family Foundation, and it's looking at growth in prescription spending over the since 1970. And in 2016, the per capita retail prescription drug spending grew at a slow rate, 0.6%, particularly in comparison to the previous 2 years when specialty drugs came onto the market. In 2015, pharmaceutical spending grew 8.1% on a per capita basis, and in 2014, these costs have grown 11.5%. Looking ahead, CMS says it's not going to be as bad as it was in 2014 and 2015. All right, so why did we see that 2010, 2012, 2014? What happened? Why did we see this huge spike? Okay, so we had an increase in our aging population, 10% population growth. We had an increase of 30% prescriptions per person, polypharmacy. There's 30% overwide economy-wide inflation, and then 30% were either doing changes to composition of meds or lending to higher price medications. And what are those higher price medications? Well, they're really specialty drugs. How many of you have heard the term specialty drugs? Okay, so specialty drugs, if they end in a MAB, yeah, that's a specialty drug. Specialty drugs are high-priced medications that only certain pharmacies can dispense on an outpatient side. So we have patients who have chronic conditions, inflammatory chronic conditions that can't get their meds, like I can't give it to you, can't get it from retail pharmacy here, you have to get it from a certain mail order pharmacy. And these specialty drugs are very, very, very expensive. As far as the spending of prescription drugs in relation to total healthcare expenditures, retail prescription drugs represented a shrinking share of the total health spending through 2013, but increased in 2014 and 2015, and those again are because of those specialty drugs. In 2016, drug spending did not grow as much as spending in other services. However, CMS projects that drug spending will continue to represent a larger portion of overall expenditure over time. Just kind of want to break it down on a per capita basis. This is spending on prescription drugs and looking at over the past decades. And when you're looking at inflation-adjusted retail prescription drugs, per capita, cost was $91 in 1960. In 2016, $1,019. And that's again, inflation adjusted. So looking at huge increase in prescription drug rates and spending. And so when you look at patients, again, more data from the Kaiser Family Foundation and Express Scripts, they wanted to figure out how many patients really can't afford their drugs. And according to the data that they presented, about 1 in 4 patients have a difficult time affording their medications. I have a hard time believing this one. I feel like the data might be a little bit different, knowing kind of the trends of specialty medications right now, and feel like it's more, in my opinion, 1 in 3 have a hard time paying for their medications. So again, when you're looking at the expenditures for costly new or for medications, it's really driven by the specialty drugs. And those specialty drugs are the inflammatory condition medications. When you're looking at the top 5, oncology makes up number 4, multiple sclerosis, HIV, and hepatitis C. Hepatitis C has been a hot button issue. If you recall, about 3 years ago, medications to treat hepatitis C were released, and they really accounted for like 95% of the drug cost to treat all of hepatitis C. And it was a very, very costly treatment regimen. The cost has come down a little bit for patients, but it is still an awfully expensive treatment. When you're looking at non-specialty drugs, where are the most expensive prescription medications currently? Diabetes, pain, inflammation, high blood cholesterol, ADHD, and high blood pressure make up the top drug expenditures. So in the retail world, generic drug prices have declined. Okay, that's good. That's good news, right, for our patients. But branded drugs have continued to increase. And when you're looking at the rate of utilization of branded drugs, and you're looking at the inflation rate is about 0.7%, but the cost of these drugs are increasing about 28 to 38%. This is just not sustainable for our patients. This increase in drug expenditures compared to the inflammation rate is just not sustainable. So I want to switch gears a little bit, since I'm much more familiar with what happens on the inpatient world. I can point to a retail pharmacy, I've been in them, but I've never worked in a retail pharmacy, so I'm more familiar with the inpatient issues that we are facing. So American Hospital Association in 2016 did a study, and it was put out to hospitals to respond to a survey. And what they were looking to see is, well, what are you seeing on the inpatient side as far as drug expenditures? And what we were seeing is an average increase of 23.4% on drug expending. And then what does that cost on a per admission basis? Well, that was an increase by 38.7%. And we felt it here. I felt it here at the pharmacy every month when I would look at how much are we spending. It made me sick to see the amount of money that we were spending on medications. And this growth in spending You know, I just got done telling you about the retail and how much money we're spending on all these specialty drugs, but what was happening in the inpatient side was happening at a greater rate, and growth in spending was happening at a greater rate than it was happening on the retail side. So remember all those numbers, and went up, feel bad now, we really feel bad, because we're really going up. And so why did we have all these price increases? Well, it's really random. There is not one good reason for why we had medications that had price increases. It's not because of our volume. I did not see our medication expenditures going up because we had more volume. It was because we were paying more for certain medications. And I think one of the issues that I really struggle with is in the hospital side, we're reimbursed based on DRG. So you get $100 a day for your patient, spend it on nursing care, Foley, wound care, whatnot, include your medications in that. And so I'm charged with making sure that we are spending the least amount of drugs that we possibly can, because I can't charge for medications individually, because most of our patients are Medicare, or in Medicaid. And so my goal is always to try to find the therapy that's best for the patient with the lowest price tag, if possible, and get the patient out of the hospital faster, because again, that saves our healthcare costs. So I really struggle with reimbursement issues, because if I have the opportunity to give the patient a $5 drug or $2,500 drug and have the same outcome, obviously I'm going to try to point toward that $5 medication. So this is data from the American Hospital Association that was released, and this is just looking at the drugs that have had a significant price increase and looking at percentage increase of some of these medications. One hospital in the study said that when they looked at price increases for 4 commonly used drugs, it ranged between 479 to 1,261%. That inflation costs the same as much as the salary of 55 nurses. So this increase in drug expenditure has caused us to cut or consider utilizing different resources that we could use on frontline associates. Now, this is an extreme example from this particular organization, but still these increased costs on medications have really put a heavy burden on the hospital. I just want to draw your attention to some examples. Nitroprusside has gone up in price 672%. So you're paying a couple bucks for it before. Now you're paying about $230 for a 50 milligram vial. For vasopressin, it used to literally be like pennies. Vasopressin, now it's more than $100 for a 20 unit vial. Calcitonin, for a 400 international unit vial, I'm paying about $2,500. And this is my favorite one by far. For a bottle of 100 vitamin K 5 milligram tabs, we are paying $5,000. $5,000. So this is a tough one to take. And when we are faced with these price increases for staples of therapy and things that we don't have other options for, we have to try to get creative in the pharmacy department. And so that's why I hound people and I say, hi, do we really need to do this, or can we try to consider this therapy? Or even with vitamin K, the injectable product is pennies. So can we use the injectable product orally and still achieve the same results versus that $50 oral vitamin K tablet? Or I'm going to start growing a lot of spinach and just make a vitamin K myself. I wanted to show you what do we spend our money here on? Now, this is not including the oncology areas, because this would be a whole different graph if this is including the oncology areas. But this is our top 20 medications. And our top 20 medications, this includes the clinics as well. So again, take out oncology, this is everywhere else in Ignesian, and this is expenditures for the last 2 years in our top 20 meds. Remicade, for example, almost $5 million in the last 2 years on Remicade. When you look at the rest of the top kind of 20, I like to blame the clinic. The clinic is really bringing us down, man. Yeah, the clinic and all your vaccines. We're paying like $150 for a Prevnar vaccine. Luckily, they're separately reimbursable. They have their own J-code in the hospital, which makes me exceedingly happy because I can make money on those, or at least recoup my costs. But when you're looking at the medications that are on there, only one of the medications in the top 20 has a generic. The majority of these medications are given in the clinic or in ambulatory infusion. When you look at the difference between the expenditures for the number 10 medication for the past 2 years and number 20, there isn't a lot of difference. And this trend continues about $200,000 for about the top 50 drugs. And so every month I review this list of medications, and every month I think, what can I do differently? Where can we save money? And what substitutions can I use? So for example, ENT, I go to ENT and I'm like, do you really need to use Ciprodex for every single patient? Are there higher risk patients that we can use Ciprodex for and then use like the $2 alternative for lower risk patients? So thank you for all of you who have had to put up with me asking for less expensive alternatives. And so how do we do some of this cost containment? Well, we do this cost containment by developing and reinforcing data-driven protocols and procedures, which is again why I constantly am knocking on people's doors. Do we really need to use this isoproterenol? Can I make it in a smaller bag? Optimizing 340B. How many of you know what 340B is? Oh, yeah, thank you. But 340B is a contract, I'm going to simplify it, a contract between government and drug wholesalers. And they say, hey, hospitals, certain hospitals, will give you medications at like a fraction of the price. And only certain hospitals qualify for 340B. And right now, just Waupun and Ripon qualify for 340B because they are critical access hospitals. Other hospitals can qualify for 340B if their dish percentage or disproportionate share percentage is high enough. St. Agnes does not qualify. Our dish percentage in this area is not high enough, but Waupun and Ripon, because they are critical access hospitals, do qualify for 340B. And what 340B does is for medications that are given on an outpatient basis, so things in the ER, things in ambulatory infusion, things in dialysis, in hospital-based areas, you can get for a fraction of the cost. There was one injection that we were giving here at St. Agnes that was about $7,000, $8,000. By shifting that patient to get the medication at Ripon or Waupun, I literally got it for a penny. And so that was a significant cost savings for the organization, which then what we need to do is demonstrate that we are having that cost savings in medications, but we are transitioning that savings to other aspects of the hospital to continue to provide care for patients in critical access areas. And then one of the other things that we can try to do is reduce inappropriate use of high volume medications. So this is a quinolone graph. I'm really kind of on the bandwagon of hating fluoroquinolones right now. So if you want to talk to me afterwards, I can give you a long list of why I don't like fluoroquinolones. The top line, that orangish peach color line, is our utilization here at St. Agnes. The line in green is comparing non-teaching hospitals, and then the line in red is looking at utilization of teaching hospitals. So this is our fluoroquinolone utilization compared to our peers in teaching and non-teaching hospitals. This graph freaked all of us out in pharmacy when we saw it. Not only did it freak us out comparing our utilization to other organizations, we also were looking at our antibiogram going, we're having some decreased sensitivities for pathogens to fluoroquinolone utilization. And so we started waging a little bit of a war on our fluoroquinolones and really saw a significant drop in our levofloxacin utilization. Now this is great, levofloxacin, even as an oral medication and an IV medication, are still rather expensive, even in generic formulation. And we started using cephalosporins, which were much, much less expensive. And so I did have to go to administration and say, by the way, you know, that revenue thing that I'm below on now, that's a good thing, because we're using antibiotic stewardship, we're cutting inappropriate utilization of fluoroquinolones, and we're using less expensive agents. So it was really a good thing that we had a little bit of a drop in revenue. I'm very happy to say that here at Ignesian, our drug budget is about $17 million for the inpatient areas. That's just the 3 hospitals, not including the cancer center. About $17 million, and last year we were $900,000 below budget. I've never seen that happen before. We have an amazing buyer who works very hard to make sure that we are working on cost containment. So I was very pleased in seeing that. All right, so to wrap up the discussion, hopefully quickly because I'm almost out of time, medication shortages. Did you guys know that we have medication shortages right now? Did you know that it's a problem? It's a huge problem. It is something that keeps me up and the majority of my staff at night. I literally could have one entire pharmacist FTE devoted just to handling medication shortages. And in a survey done by ISMP in 2010 and 2011, where medication shortages, the numbers were at their worst, not maybe the types of drugs, but the numbers were at their worst, you can see that it did have an impact on patient care. And so what are really the causes for these medication shortages? And if you look, over 2/3 of the causes are really quality-related issues, the manufacturing delays and capacity delays. And so what are some of the quality issues that companies are seeing? Mold. You guys remember New England Compounding Pharmacy, mold in their compounding area? Yeah. FDA is becoming much more stringent in how they check these areas, and which is why we have USP 797. But that shuts down areas. We have equipment that fails. So then you have a product deficit and a defect, and so then those are pulled off the market. And then what happens is you have these recalls. And I think what really compounds the issue is that a lot of our generics, and I just got done talking about, they went skyrockets in the price of generics because they're single source, meaning there's only one manufacturer. So, for example, right now we have an opioid, because there's really one manufacturer for the bulk of opioids right now, and I'll talk about that. And so not only can they drive up the price, but when they have issues in that one plant, that one manufacturer, it shuts down the supply chain for everybody. So you're looking at shortages, top of the graph, and this is information from the FDA. Talks about shortages reported and shortages averted. You can see it looks like it's great. It's like an inverse triangle. Like, hey, these shortages are getting way better. No, they're not. The shortages that we were experiencing in 2010 and 2011 were shortages of things like multivitamin or selenium injectable, like things that don't really, I mean, they make a difference for some people, but not really make a difference on day-to-day for hospitalized patients. The shortages that we are seeing now are things like IV fluids, opioids, injectable local anesthetics, and I'll again touch on that. I will honestly say that 2017 and 2018 have been the worst years for critical medication shortages that I have ever experienced, and I don't see it lessening up anytime soon. And so the FDA was so kind enough, Dr. Gottlieb put out a statement back in May about the medication and shortages that we're having. And he said, without question, one of the most frustrating challenges that healthcare providers and patients must contend with is that when drugs that's medically necessary and critical to patient care is unavailable due to shortage. We know that the uncertainty over how long a drug will be in shortage, how to ration supplies in the meantime, or worse, how to prepare for sudden event that might place unforeseen demands on a product that's in short supply adds burden and stress to providers and patients. Heck yeah, it does. I was like, you bet, yeah, you know that, friend. And then he goes on to say that the FDA also understands that hospitals and other healthcare facilities can feel blindsided, yes, by these shortages. They seem abrupt, they are, and maybe. Drug shortages have also had significant cost to our overall healthcare system, and the FDA is committed to taking new steps to address the root cause of more of these shortage issues. Okay, so what has the FDA done? In 2012, the FDA put together an act. It's the Administration Safety and Innovation Act. And what they said is like, hey, if manufacturers, if you guys are like not going to be able to make something, can you call me at the FDA and can you let me know? Sounds great, right? So then the FDA can start a triage plan and work with other manufacturers to bump up production of those medications. Guess what doesn't happen? Nobody tells the FDA. So the FDA, they have this act, but it's not necessarily followed. The FDA has also been expediting review of certain medications, facility inspections, and they've even allowed extended dating of expiration of some products. So for example, our emergency medications, epinephrine, that we could not get for a while, they allowed expiration dating, extending of several months to allow us to still have epinephrine here within our healthcare system. The FDA also says, hey, guess what? It's the worst time for shortages right now. They're getting better, but the things that are short are really kind of scary, and that is true. IV fluid shortage. So in 2017, we had a hurricane in Puerto Rico, and a lot of our IV fluids, bulk of our IV fluids are manufactured in Puerto Rico. Also, earlier, before the hurricane, one of the manufacturers said, oh, by the way, you may just want to stock up a little because we're going to shut down this plant. And so me and pharmacy started panicking. We're like, oh my gosh, they're going to shut down a plant. That's not possible. So we started ordering, which is like one of the things you're not supposed to do, but I like to be a little bit prepared. So we started hoarding. Please don't tell the FDA, but we do. And so luckily, when the hurricane hit, we had an adequate supply of IV fluids, already a little bit hoarded. So we were lucky. We were lucky compared to a lot of organizations. We still did have to change some of our practices. Some of the medications that we were hanging in mini bags, we had to do an IV push. And so things like, what are we sending the patients to surgery with? We have them switch to LR. We're like, no, they have to stay on the regular fluid because we literally don't have extra IV fluid laying around. And so the manufacturer said, this will last 6 months. You'll be fine. Yeah, this was a year ago. We're still in our hoarding and counting how many IV fluids that we have and still working in conservative measures to maintain our IV fluid supply. And I don't see this ending in anytime soon, and it will go well into 2019. Injectable opioids, this has been a very difficult one for us. We've had to change practices as far as how we are going to dispense opioids to our patients. We have had to change how we compound opioids because we have not been able, frankly, to get them. And so we've had to go to third, fourth, and fifth line patients, or treatment options. And it's really because of Pfizer. Pfizer has like one plant where they make this, and it's in Kansas, and it's having problems, and Pfizer's like, oh, by the way, this is gonna last till 2019. Good luck, guys. And so we are looking at alternative types of therapy, switching patients to oral. It is in fact impacted on how we can treat our hospice patients with injectable opioids as well. Local anesthetics, yeah, we can't get those right now. Lidocaine, any of the canes that has a cane at the end, we can't really get that right now. And so we are working to try to mitigate that. Do you really need the cane for this? Can you use a multi-dose vial? Do you need preservative-free? So thank you to all of you who, again, have made changes because of the shortages. The FDA has a lovely little app if you guys want to stay up to date on the shortages. There's about 20 added every day or updates to those shortages every day. And the information that's put out by the wholesalers and the FDA is really not very accurate. They'll say, hey, the shortage will resolve in September 19th. And September 19th will come and go, and then you'll look back on the website and be like, just kidding, November. And then you'll look back in November and be like, yeah, no, it's still not there. So that's what some of the frustrating part is for us in pharmacy is getting the information to frontline providers saying, hey, this is the shortage, this is what it's going to go away, you can expect it to be better. Okay, great. We have issues with that. We really have been struggling with finding a resolution to some of these shortages. What do we do here? Okay, well, I already admitted to you that I stockpile, and you have a whole room of not only IV fluids, but other medications that we stockpile. We really try to look for therapeutic alternatives. We avoid using the gray market. Gray market is a third party that will buy medications from wholesalers, jack up the price about 600–700%, and then resell it to you. So I try to avoid using wholesaler, gray market drug distributors, and also I cannot necessarily guarantee the medication was stored appropriately per FDA standards. We've been compounding things in the pharmacy, so we've taken multi-dose vials, we've drawn them up, we've labeled those, and that all comes with a risk of error as well, because this is a change in pattern from what providers are used to using. We also alert providers. No, not all of you get emails every day, but what we do is we have identified key classes of medications and provider groups that we do need to notify in case these are short. We used to say, well, we'll let you know when we have less than a 30-day supply of the medications in-house. We couldn't even keep up with that because, as the FDA has said, they happen just like this. One day you can have a full supply of lidocaine 1%, and then the next day you go to order it, and it's not available. And so we try to do our very, very best to update all of you frontline providers when we do have medication shortages. So that was the potpourri of pharmacy for today. Those are M&Ms. They're not pills, but I thought they looked close enough pills, so I thought I'd use them. What questions do you guys have for me? Yeah.
What is calcitonin used for? I mean, why are we paying thousands of dollars for calcitonin? I don't understand.
It has a couple of different uses. It has surgical utilization. It has hypercalcemia utilization, bone marrow or bone density utilization as well. And so we're really trying to avoid utilizing it here on the inpatient side for some of the hypercalcemia treatments. Yeah.
Are providers agreeing with your suggestion to use biosimilar?
Yeah. We're getting there. It's been a slow and steady course. I've really been hitting up the GI providers hard because they're a big utilizer of Remicade. And so I have seen acceptance of using Renflexis. And it's nice that CMS about last year said, hey, you know what, we're going to pay you the same as we pay you for Remicade. And so until the insurance companies started recognizing some of the biosimilars, we had some issues there. One of the things that I think I really struggle with is Johnson & Johnson, who's make our Remicade. They came in and I said, hi, I need you to give this to me lower price because I'm gonna use the biosimilars. You're gonna lose us as customers. And Johnson & Johnson said, no, we're not gonna drop the price at all. And I was like, okay, fine, I'm gonna use all the biosimilars. But what we're seeing is that the insurance companies are now saying, oh, you have to use Remicade. And I'm like, Johnson & Johnson, are you guys serious? Can't we just save some people some money, for God's sake? So we're seeing some issues there with the biosimilars. Where insurance companies are kind of backtracking now. Yeah.
You mentioned certain drugs are cheaper at our other outside hospitals. Are there certain medications we should refer our outpatients to go to Ripon or Waupun so it's less expensive for them?
That is an excellent question, and we have an entire pathway designed for that. So if you refer somebody to St. Agnes, for example, and there's an opportunity to get the medication, we have a workflow that allows for us to do that. So you don't have to do it, we kind of do it on our end. And it's in the conversation that we also have with the patient then to say, you know, why we're moving them to a different site. Other questions? Yeah.
One comment regarding your statement that the increasing prices of medication seems to be a random event. I tend to think that it's not random and that it's due to obscene profits of the pharmaceutical companies manufacturing this.
I will agree with you on that. My statement about random is I never know which drug it's going to be next, especially with the generics. With these single source generics, one day you're paying $1, the next day you're literally paying $700. It's very frustrating because you don't see it coming.
Well, the reason they're doing it is they can get away with it.
Correct. All right, good. Other questions?